Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm Yaron Ivan, your host, Pediatric Emergency Medicine Physician in Orlando, Florida. And today we're continuing some discussion of some very important rules that I call communication tips and tricks. Those are some rules that help me communicate to my colleagues, my patients, my consultants, my nurses. I literally use those every day, and I find many of them to be very helpful. Rule number 56. Worried parents don't go home. This is something I teach the residents, especially the interns, very often. By definition, most of the time, a parent who is bringing his or her child to the ED is obviously worried about something. Now, most of the time, I find that the child is really okay and the parents are worried about some normal or mild presentation that was interpreted or misinterpreted as bad or serious. A good example, they thought the runny nose and the fever was a serious illness. They thought the abdominal pain was appendicitis, etc. It is therefore important, in my opinion, to address their concern and make sure we address them well and that the parents are not worried by the time they are discharged. So I always do everything in my power to address the concerns and unworry them. So I work with the parents and I do whatever I can to prove to them that the child is okay and safe to be discharged. However, I do that without breaking my commitment to the child who is really my patient. And what do I mean by that? Very often I see parents coming to the ER, let's say, with chief complaint of abdominal pain for the last 8 months. 8 months of abdominal pain without some serious red flags like weight loss are very unlikely to represent anything serious, emergent, urgent, definitely not surgical. However, obviously the parents are very worried because it's been 8 months, the child is not necessarily getting better, missing school, etc. So I do my very best to explain that serious surgical issues present themselves much earlier than months. I explain that little Maggie's exam is reassuring. I explain that there are no red flags by history like weight loss. Like I said, I do my very best to address their concern and reassure them. At the end of my little speech, if I think the patient is safe for discharge, but the parents are still concerned and they ask or demand some blood tests, I don't hesitate and I just order those tests. In my opinion, that is a small, harmless investigation in order to reassure a worried mom or dad that the patient, their son, their daughter is fine and is safe to go home. Especially given the possibility that if I don't address their concern, they may just take their child to some other facility and the whole process starts from square one. If a normal CBC and comprehensive metabolic panel will put the parent to ease, so be it. No big deal. If the parent of the child with the runny nose and fever is worried about pneumonia and my little verbal reassurance did not put them to ease, I order that chest x-ray with no hesitation. Small price to pay, in my opinion. In my opinion, a blood test or an x-ray doesn't break my commitment to my patient. Having said all that, I personally don't do a CT scan on a patient just for patient or parent reassurance. I personally don't give antibiotics to the child just for parental reassurance because that, in my opinion, is not fair for the child who's really my patient. To me, those are possibly harmful and break my commitment to the patient. I explain to the parent that a CT involves radiation and I don't think it's indicated. And because I don't think it's indicated and because it's harmful for the child who is my patient, I can't do that. I also tell them that if I think this is a viral illness and there is no medical indication for antibiotics, I cannot, in good conscience, give the child antibiotics for that. So I think it's very important to address the parents' concerns while keeping the commitment to the patient, the child. Another example was a few weeks ago, in the midst of this very mild bronchiolitis season. I had a 4-month-old baby with mild bronchiolitis who had no indication for admission, no hypoxia, good PO intake, and no distress. Those are the 3 indications for admissions for all kids with respiratory issues. The child was in day 3 of illness, so possibly will get worse. Though there were no indication for admission, the mom felt very worried going home given the possibility of worsening. I explained that given how the baby looks now, it is very reasonable to be discharged and I think more likely than not, he will be fine. But my words failed to reassure the parent. And let's be honest, I can be wrong. I ended up admitting the child due to parental concerns, and the hospitalist never said anything. So, rule number 56, worried parents don't go home. Either unworry them or admit the child. Rule number 57, set up the expectations. This, I think, is a good rule to communicate to parents with regards to their child treatment. Anytime I prescribe treatment that I know there is a chance it's not going to work 100%, and very few things do work 100%, I set up the expectations. Also, I also set up the expectations with regards to the ED operations and the amount of time things will actually take to complete. Let me explain what I mean. So let's say I see a 16-year-old girl who's coming to the emergency department with abdominal pain. And let's say I have some concerns because it's right lower quadrant, she's vomiting, etc. Obviously, I'm worried about appendicitis, and you can't really be worried about appendicitis without investigating the possibility of ovarian torsion as well. So now we are looking into some labs for the pediatric appendicitis score, IV access to give fluid so we can use the full bladder to see the ovary. We need to get two ultrasounds. The ultrasounds have to be read by the pediatric radiologist. Let's face it, we all know that many times the ultrasound doesn't even see the appendix, so now we're back to square one. Before you know it, it's been 3 to 4 hours and you don't really have an answer. Parents really have no clue sometimes that it can take that long to complete this investigation. So saying something to the mom and dad, "Mom and Dad, I'm glad you brought your child. I do think that this abdominal pain is possibly from something serious. We're going to take some labs and do some ultrasounds to look into that. Please understand that the investigation for abdominal pain in a teenage girl can be a little long. You might actually be here for a few hours. I apologize in advance." I feel like if you don't say that 3 or 4 hours later, when the ultrasound has not been done yet because the bladder is not full yet, etc., you have some very angry parents who are just unaware it's going to take that long. So set up the expectations. Another good example for setting up the expectations is when I provide some treatment which is possibly not going to be very helpful. So for example, if I see a child with allergic reaction like hives, very often I give Benadryl, but I make sure I set up the expectations. And I say something like, "Mom and Dad, just so you're aware, little Maggie has an allergic reaction and Benadryl is the medication for allergic reaction. However, Benadryl doesn't cure allergic reactions. Benadryl simply blocks histamine, which is the cause for the allergic reaction. But if there is a lot of histamine around, little Maggie may still have symptoms. It's very important that you try to figure out if she ate or drank something new or if there's something new in her environment, and try to eliminate that. Until then, Benadryl is totally fine, but I don't want you to think it's a cure." In my experience, if you don't say that, parents give the Benadryl, and if little Maggie still has hives, they're going to be very worried that something serious is going on because they're giving the medication and there is no significant improvement. When in reality, if little Maggie has an allergic reaction to the cat and the cat is still around, well, guess what? Little Maggie is still going to have hives. So set up the expectations. Rule number 58. Good feedback is best served warm. In my hospital, which is one of the things I like about it, I work with a lot of trainees. Medical student, pediatric, emergency medicine, family medicine residents, and some PA students as well. And it's really one of my favorite things to do because I love teaching. And I feel very strongly that in order to grow as a provider and as a person and as a physician, you really have to get good feedback, learn from your mistakes, and do the right thing, hopefully, the next time. That is why I often give feedback to my residents and my trainees at the end of the shift. So during the shift, I try to take a lot of notes, and I often take 5 to 10 minutes at the end of the shift to provide them with some feedback. And I also tell them, "Hey, so-and-so, why don't we go for a few minutes aside and let me give you some feedback about your shift today?" I think it's very important to remember that good feedback is best served warm. Because if I speak to the resident about the shift and what he or she did, what was good and what was not good in 2 or 3 days, they're not going to remember. They're not necessarily going to care. So good feedback is best served warm. When the resident is done with the procedure, I take the 2 minutes to give them some feedback about the procedure. When the resident and I finish the shift, I take a few minutes to talk to them about what we did, what we learned, etc. Reinforce some specific principles we spoke about, because good feedback is best served warm. It's done at the end of the encounter, at the end of the procedure, or at the end of the shift. So remember, rule number 58. Good feedback is best served warm. Rule number 59. Don't tell me what will happen. Tell me what is happening now. This rule simply stems from the fact that I think even the most experienced physician can't really predict what actually will happen. I heard it from a friend who used to say to his employees in a very big company he ran for many years. I think people tend to not recognize the fact that we rarely can actually predict what will happen in the future. What really triggered me to think about this rule and include it in the podcast today is when I saw a patient in the emergency department a few months ago with the chief complaint of congestion and runny nose, a very URI-like chief complaint, something that sounded very viral. The resident went to see her, and when she came back, she presented a well-appearing child and noted that on otoscopic exam, the TM was red. When I asked her for her assessment and plan, she mentioned she would like to give the child amoxicillin because although she did not think the child has acute otitis media, that red TM can become one or will become one in a few days. I said, that is certainly possible, but it's also possible it may not. Why give antibiotics for something that is just possible? I personally consider antibiotic serious medication. I have intubated patients for anaphylaxis, and the chief complaint of allergic reaction due to antibiotics is a common ED chief complaint. So I asked the resident, right now, do you think this is bacterial otitis media? Right now, do you think the child needs antibiotics? The answer was no. So rule number 59, don't tell me what will happen, tell me what is happening now. That is it for today, guys. Thank you again for listening and tuning in. I appreciate it. Let's review what we learned. Rule number 56, worried parents don't go home. Either unworry them or admit the child. Rule number 57, set up the expectations. Rule number 58, good feedback is best served warm. And rule number 59, don't tell me what will happen, tell me what is happening now. And that is it for today, guys. Thank you very much for listening. I hope you liked the episode. Please feel free to check out pemrules.com, provide any feedback or any suggestions or requests you have for future episodes. I hope you like our little outro today, and see you next time. Have a great day.